Hello, hello, mic testing. 1 2 3 4. 1 2 3 4. Mic testing. Hello, 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 hello. Mic testing. 1 2 3 4. 1 2 3 4. Hello, 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 hello. सर मैं इधर से उस साइड चल रही हूँ। थैंक यू। सर माइक माइक हाँ माइक ऑन हाँ कनेक्ट कर दो. Now, what I wanted to explain to all of you, you see that's the pylorus, correct? Now, when I pull my scope back, okay, that's the incisura, okay. Sometimes you have a fold which is very close to the pylorus, which looks like incisura. It's not incisura, okay. Now, I start from here, the junction between the greater curvature and the anterior wall of the stomach. Is it clear? Mhm. So, that's my first bite. Then, the second bite is again here. Release कर. Okay. So, you see I have crossed my suture. Can you see? I have to untwist it again. So just a simple action like that, okay, and I have untwisted, correct? So that's how. Now I'll take my third bite. So we go here, right? Okay. Now see how nice the quality of bites are, correct? Now when I have to take my fourth bite, I won't go here because that's the no-go area. Okay, otherwise I will obstruct the complete lumen. So what I do instead, I turn back like that and I go extremely posteriorly here. Okay, got the point? And then I turn back again and take a bite. Can you see how I took the posterior bite? Instead of going exactly like not on this, I went here. Okay. Now again we have to go here. That's the posterior wall. Okay, go again. That's a very thin bite. So go again. One more. Okay. Now this is better. Okay. Leave it. Okay. So now we have good bite here. Can you see? And the lumen is getting approximated. Again, I would go further here on this side. Take one more. लो और लो और लो और लो और लो. ठीक है. ओके छोड़ो. फास्ट करो तुम. मेरे हिसाब से मेरी पेस से करना है तुमको. अपने हिसाब से नहीं करना है. ओके नाउ आई विल गो मीडियल. करेक्ट. सो आई विल गो हियर. लो जल्दी. फास्ट. ओके. Again, you have to see that we don't have to leave plateau of tissue. Okay. So I'll go here and I'll pick that tissue. Can you see that plateau? So now it gives me a good full. Okay. Now always I have the freedom of taking the scope a little back. Okay, just like that. Because the tissue coming towards me is always bad. So I can take this a little back and now you see. Okay. Again I got the orientation. I can put it here. Okay. Okay. Now what you see? You see nice approximation. I started from that point and I ended, but what I will do is I will go further above it. Okay, so I'll go somewhere here. Okay, just to make a nice. Now that's a nice first round. I drop the needle here and then see what I do. Take this inch. I completely evacuate and I hold it like that. See, that's how the quality of my bite is. Can you see? And then in the meantime, he's going to use the cinch. So that's the cinch. Okay. And I'm going to put a tag at the end of the suture. so that it holds in place. Okay. So now what I'm going to do, and now you see, I am here exactly at that point. I hold this close to my chest like that. See, it's just like that. Okay. I push this and I pull the suture. Okay. If I don't hold it to my chest, it's not possible. Can you see? Okay. Fire this inch. So he drops the safety and he fires it. Okay. Now you see the quality of my bite. Can you see? And now we have the entire orientation of the tube in front of us. So now nobody needs to explain. You know that the first round of bite, if you take it properly, then already the lines of forces are aligned where you know how to take the bite. Okay. So again, I will go, I will take a loop. Sorry, always remember to close it. I take a loop. Okay. And now where do I start? So before doing anything, I first try and see the area nicely. I'm in no haste to start. So where should I start? Tell me. Point, where should I start? Tell me. Very nice. A little up. A little up. Yeah, correct. So this, I start here. As he has said. Okay. I pull the tissue towards me. Take a bite. Go back. Okay. Leave. थोड़ा फास्ट लीव करना है ना, मेरी स्पीड के साथ चलना है तुमको, ठीक है, तुम्हारी स्पीड से नहीं चलना है. ओके, हियर, लीव, लीव. If there is some bleeding, just don't bother, it will automatically stop. Okay, now I go, I took it here, now I go here. Okay, let me remove some air. Now you see, when I remove air, it comes easily. So we have to learn how to work under less and less pressure. Okay, now got this. Can you see the thickness of the tissue? I pull it back. I reorient myself. Now it has to come here. Okay. Now I have reached the base of the U. So where should I go? This area. Now there are two ways. Either I dip it down here and I go this way. That's one of the ways to do it. Okay. Now I need to go here. Okay. This area. So I need a nice base. Take it. 1, 2, 3, 1, 2, 3, 1, 2. Okay. And I dip this. Leave it. Leave that area. We'll go again. Okay. Nice. See? Nice tube. Now I'm gonna go a little medial here, or maybe I can. Okay, that's fine. I can go here. Good. And now I can go a little medial here. So let's go there. Yeah. Go. Hmm. That's the plateau. Okay? We don't want to leave space like that. Hmm. 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 Correct? And then I always love to take the roof a little bit just so that my this one. I always like that. It looks neat. Now I'll drop the needle. Hmm. Okay. And then what do I do? I remove all this air. Hmm. I tighten it up. One, two, three. वन टू थ्री चल 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 तुम काय को रुके हो तुमको क्या हो गया है स्लो नहीं करना है okay again what I explained what do we do now see this guy has just left this he doesn't know one should not leave it till the time I hold it this guy just left and went there doesn't understand so your assistant should not leave it should keep it tight okay now see I keep it tight one two cinch drop the safety and cinch. Can you see how tight the tube is coming? Now the third. ऐसे नहीं छोड़ना होता है किसने सिखाया ऐसा Okay, now see push, make a loop. Hmm? Okay, now where do I start? Where do I start? Please tell me. Very nice, very nice. So let me go. Boom, there. I'll go inside the gap. Okay, because I want to. Can you see? I can pull all this tissue towards me. Leave it. Leave. You have to be fast. You can't just. Okay, now if I want to go further there, okay, boom, start. Leave, leave. Okay, okay. Now you see that's the area. Leave. I'll take another one. Let me go. Boom. Yeah, take it. Nice, nice bite. Leave, 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 leave. Okay. Hmm. Hmm. Let me go here. Okay. Leave. Okay. Now here. Let me go this. Leave. Okay. Now what should I do? I'll pull the scope a little back, okay? See how my orientation changes. Initially, everything was coming in front of me, but I just changed my orientation, slight laparoscopy. You have to go back and forth. No, I'm not going to go there. That's the no-go zone, okay? My tube is coming up really well. I'm not going to go into that zone. This is good. Leave. You have to be fast. You're very slow. Okay. Now I want this. Maybe this. Okay. Now see the beauty. No, that's crossing. Okay. Boom. Okay. Leave. Nice. Okay. We are actually at the fundus, correct? That's why we are having a little tough time. But okay, I'll manage. Okay, now you see my position. Hmm. Can you see my position? How I am managing it? Leave. Very slow air. Crossed. You uncross it. We always make sure that we are like that. Okay, now it's fine. Now, boom. Hmm? Leave. Hmm. No. One. थोड़ा कम कर. Good. Leave. Okay. Okay. One more. Hmm. Hmm. Leave. Okay. Good. Okay. What do you say? Hmm? One more? One at the top? Or we can go on that side also. No space. No space. Okay. Let's do a trick here. Let me go. Leave. Nice. I think I'll go here at the top a little bit and then I'll drop. Usually they just drop it here, but I just gonna go here and no. Okay. Hmm. Hmm. Leave. Okay. I think that's good. So let me reduce the pressure completely. Again, see, when I have tightened it up, pay attention to what he is doing. He is first trying to put it through the cinch. It's very simple. We will explain you how to do it. It's just like to put that thread inside that. Now, till the time I am keeping it tight enough, he need to maintain the pressure. What he did last time, dropped it. Because when I bring it to my chest, my focus is on bringing it to chest. This guy should maintain it pressure, and now he should keep maintaining the pressure till the time I completely put the cinch at the base of the suture. Okay? Yes? Pakka? Needs to understand. Okay, now I'm here. Okay, now he can leave it. So I put it to my chest and I do like this. 1, 2, 3, 4. Okay, cinch. Good. No, I don't think so. Let's see. Let me close my device. I should always close my device. And this, there's no scope. What do you say? Correct?
Hello, Mohit.
And the tube looks good. Hmm? There's a small fundus here which I'm not gonna disturb. I'm just gonna pull this like that, and then automatically I can at the same time. Oh, good. We just completed. Okay. Hi, Manuel.
Hello,
Can you
Mohit.
hear me?
Yes, I can hear you crystal clear. Can you hear me?
So take a single lumen
Hello,
scope, and
hello.
I can do an endoscopy and demonstrate it to them. So what is the principle? The principle is that these things they take 15-20 minutes. You just need to take the first round of bites very correctly. So you need to have the good you first, and then automatically you will get the and the communication with the assistant has to be very clear. You cannot just keep on communicating. So tomorrow you're gonna assist me. You know how you have to do. The moment I take a bite, I at least I realize that I can exchange my needle or not. If I'm not able to exchange it, I'll automatically tell you. But once I take the bite, I commit to it. You have to start to unwind. Otherwise, if I keep on giving you instructions every other time, it's gonna take 2 hours to do the same procedure. Okay, I can see him, but Manuel, can you hear me? But I
Yes, I
can't,
can hear
I
you.
can't hear what he's saying. Okay, so Manuel is going to perform at least help you perform at least 15 to 20 such procedures tomorrow. So don't worry, you're going to get good amount of time with him. Um, so that's the final picture of the sleeve. And I always believe we should put in a single lumen scope and check. Okay, so that's my Z line. Is it okay? So I just enter very slowly, and now you see. Hmm? That's a very small little fundus here. Can you see? That's important for the satiety. Otherwise, if I take sutures here, I can take some sutures there, but then there is no satiety because we need a pouch beyond which there is an obstruction. So patients feel full. Okay, and then I go inside very slowly, slowly, and boom, there is my pylorus. Can you see? And then when I take this, okay, and usually we can discharge this patient by evening today. If there was a lot of blood in the fundus, I would have sucked it completely, but there's just little. I don't want to keep sucking. But usually we start with sucral gel after the procedure, and we can send the patient home in the evening. Any questions? Yeah, I usually follow them up at 3 months, 6 months, 1 year every time. But I don't do an endoscopy. Obviously, we can do it as a part of a clinical study, but it's not recommended. It's not necessary. Anything else you want to ask? It will handle it automatically. If starts to bleed, just keep on suturing. You are talking about bleeding while doing the suturing or bleeding post-op. When do you while immediate or delayed immediate bleeding you keep on suturing, like you do in general surgery. You suture, and the tissue which covers that bleeder will stop it by the pressure. You know, but if you're talking about bleeding post procedure, that will happen in some cases where I did not suck the blood from the fundus, so the patient might vomit, but it's not active bleeding. And still, if the patient actively bleeds and the hemoglobin drops by more than 4, which has not happened to me, very rarely it happens. Specifically in revisions, it happens sometimes, but not in virgin cases. But you can always go inside with a scope and suck all the fluid and then come out and see where there is active bleeding. So usually we keep them on a liquid diet for around 15 to 20 days. Most recommendations would say around a month, and then they can start with solids, semi-solids, and then solids, like bariatric surgery. Here we put them on a liquid diet for a longer duration of time because we want healing to happen and permanent fibrosis to set in. And patients tolerate it very well. They don't like to eat solid food, but this is very restrictive. This is like sleeve. You saw the sleeve endoscopy. It's more restrictive than that, so they comfortably tolerate it. Yeah. So, so, so if you have extra gastric tissue, it will not come to you very easily. So tomorrow, when you will assist me, yeah, 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 just you'll realize if you have resistance, just unhelix it, the opposite side, and then you will have a loose tissue coming to you. So the feeling. If you try to pull all the things towards you, you can even take liver, gallbladder, or whatever. But it's not happened with me because we always leave it there, and that is a feel which you will get. I'll give you both the feels. So while pulling, you can understand. Mhm. So I usually do 1.5 to 2. I don't try to dig in too much. Everybody is different. I would not want them to dig in more than two and a half, but very slow.